Good evening, students. Welcome to you from Sri Rama Hospital, Jagaipet. We are learning skin and soft tissue lesions. In that, yesterday we learnt about dermoid cyst, various types of dermoid cyst. Today, let us study about the other skin lesions. This is the hematomas, the benign lesions, then the malignant lesions. So now let's study about the sebaceous cyst. Okay, good evening, dear students. There is there was some little problem with the network. That is why I was unable to connect to you. Now I hope everything is okay. You are able to see. Okay. Okay. Sebaceous cyst. Sebaceous cyst. The synonyms being epidermal cyst, epidermoid cyst, and the wen. Sometimes you will find the question in the theory examination as when. So one time it was given as when. So please be aware of this word when is equivalent to the sebaceous cyst. Etiology, it is a retention cyst of sebaceous gland. Obstruction of the orifice of the sebaceous gland. Downward growth and accumulation of desquamated epidermal cells in a sac lined by superficial squamous cells. So actually, the sebum is secreted from the sebaceous glands by dissolution of its epithelial cells. So it has epithelial lining cells are there. So these lining cells are dissolved and they become the sebum, and that sebum is excreted onto the surface. So there will be downward growth of these of the epidermal desquamated epidermal cells into the sac, and they get degenerated there and they form the cyst there. So that's why it is also called as the epidermoid cyst, because the epidermal cells has formed into the cyst. That's why it's called the epidermoid cyst. Now are able to visualize the video and then the slides. Okay. Santi, what about you? You said that you are unable to see the slides. Are you able to see now? Okay, that's fine. Clinical features. It occurs at all ages. Site, any site except on the palms and soles. Why sebaceous don't occur in the sebaceous on the palms or soles? Why they don't occur? Yes, because there are no sebaceous glands in the palms and soles. More commonly on the face, scalp, neck, and trunk. Presents as a painless swelling which cannot be moved apart from the skin. So it appears like a skin swelling, but as it is skin swelling, it moves with the skin. Size variable, maybe a small size like a pea size, or it may be very large size like football size. Soft in consistency with sign of indentation. What is sign of indentation? If you press the cyst, for example, here, you press it with your thumb. Take away your thumb. The thumb impression will be seen as a depression on the cyst. That is because the cyst contains some pultaceous material. So, with indentation or with pressure, the material displaces and it leaves behind the impression of the thumb. Presence of punctum on a small dimple or on a small elevated hyperpigmented papule. So you can see here there will be a small pigmented lesion. Small, it may be like a dot or it may be like a papule. So that is called the punctum. So that represents the blocked sebaceous gland duct. Sometimes it may be multiple. Then it's called as the Gardner syndrome when it is associated with desmoid tumor, intestinal polyposis, and osteomas. So this is the punctum here, and here the punctum. Sometimes the punctum may be large like this, and this is the punctum. Sebaceous on the scalp, the characteristic feature is they do not have the hair over that. So there will be baldness over the swelling. So this is sign of pitting, you can see. So the thumb impression will be left there. So this is called indentation. You can see here when it's being pressed, so there is a depression here because it contains pultaceous material, so it presents like that. You can see this is a very large sebaceous of the thigh. So this is the cyst, and here is the punctum, and it contains the material like this. Sometimes there will be multiple sebaceous like this. So the gentleman is having about 7 or 8 sebaceous over the scalp, and he was also having the osteomas. Complications of sebaceous infection leading to abscess. This is very common. So you can see there is hyperemia, there is pain and tenderness, and this is abscess of the sebaceous cyst. Ulceration, Cox peculiar tumor, ulcerated and infected sebaceous cyst resembling epithelioma. Sometimes a sebaceous cyst over the scalp may become ulcerated and infected, and it may produce foul smelling material from the swelling. Then you call that as Cox peculiar tumor. Occasionally, the sebaceous may complicate as sebaceous harm. This is sebaceous harm. So all the readers of Bailey and Lowe textbook of surgery, they are very familiar with this image because this is the favorite photograph of Hamilton Bailey. So from their early editions onwards, they are printing this on their front page. This is sebaceous with ulcer. So how do you differentiate between dermoid and sebaceous cyst? Dermoid is subcutaneous swelling where skin can be pinched all over the swelling. Sebaceous cyst punctum is present and the skin is adherent around the punctum to the skin. So you cannot pinch the skin around the punctum because skin is adherent at that particular place. Dermoid occurs at junctional lines. Sebaceous occurs anywhere except soles and palms. The underlying bone shows scalloping or depression in case of dermoid, and there is no scalloping for the sebaceous. Why is there scalloping for underlying bone in dermoid? For dermoid cyst, why there is scalloping of the underlying bone? Pressure effect means even sebaceous cyst also has a pressure effect over the bone. Then why is it not producing the scalloping for the sebaceous cyst? Why is it producing only for the dermoid cyst? Yes, because of the embryonal development. Dermoid cyst develops along with the bone. So during development of the bone, the dermide also is present there. So then it causes some obstruction. So that's why that particular area of dermoid is devoid of the bone. So there is a depression on the bone. Treatment: excision of the cyst along with the punctum and including the entire wall. So the whole wall of the cyst wall has to be removed, and you must remove the adherent skin along with the punctum. That is very important. If you leave behind the punctum there, then it will sure to recur. And even if small part of the wall is left behind, it can again regrow into sebaceous cyst. Recurrence is likely if part of the cyst wall is left behind. In infected cysts with abscess, so if the patient presents to you with abscess due to sebaceous cyst, then what do you do? First of all, you incise the abscess and drain the abscess, followed by excision after the infection is controlled. Other variants: meibomian cyst. It is epidermal cyst on the free edge of the eyelid. Chalazion. It is a chronic meibomian cyst. Tricholemal cyst. These are derived from the epidermis of the root sheath of the hair follicle. Usually, they are multiple and frequently occur on the scalp. That is about sebaceous cyst. Now let's go to the other topic: other cystic swelling in the subcutaneous tissues. That is the cysticercosis. How we know the cyst wall is completely removed means when you are exercising, you must be always over the surface of the swelling. At no time the cyst wall has to be punctured. If cyst wall is punctured, the pultaceous material will come out. So without rupturing the cyst, you have to remove the cyst complete. If by any chance you puncture the cyst, you evacuate all the contents out, then you hold the cyst wall and you gently excise the whole cyst wall from the surrounding tissues. By looking at the cyst cyst wall, you can say whether it is completely removed or not. Once you see, yes, there will be delineation between the surrounding tissues and the cyst wall. You can make it out. Okay. Next is the cysticercosis. It is due to the tinea solium, the tapeworm. So the adult tapeworm lives in the gut. The eggs are passed in the human feces. The pig devours the feces, and this eggs passed into the pig's alimentary tract, and they become cysts in the muscles of the or subcutaneous tissues of the pig. When this pig flesh is being eaten by the man, these larvae, which are in the form of cysts, will enter the intestine and they become differentiate into the adult tapeworms. That is the normal course of the life cycle of the Tinea solium. Sometimes what happens is these eggs contaminate the water source. That means the fecal matter contaminates the water source. So the person will be taking the contaminated water. The eggs will be swallowed by the adult human being, and these eggs now they pass into the alimentary tract and they penetrate through the gut wall and they enter into the circulation. They go to the liver and other structures and they form the cysts all over the body. That is how cyst sarcosis occurs. You can see this is the subcutaneous swelling, a spherical swelling. So the swelling is removed here. You can see when it's cut open, you will see thick walled cyst with little fluid or embryo inside it. It's just like hydatid cyst. Cysts may occur in subcutaneous tissues, muscles, or any organ. These cysts may grow for a certain period and later may get calcified. Complications, infection leading to abscess. Diagnosis, you can diagnose it by doing ultrasound scan or CT scan for cranial structures. Differential diagnosis, you are differentiated from abscess, fibrosarcoma if it is there in the muscle. Any swelling in the muscle, first a neoplastic lesion has to be suspected. That's why a cyst, a large cyst in the muscles maybe have to be differentiated from the fibrosarcoma. Treatment, albendazole 15 milligrams per kg body weight for 4 to 6 weeks. If the cyst got calcified, you have to remove the cyst along, you have to do excision of the cyst. So that is the examples of cysts in the skin and subcutaneous tissues. Now we'll go to the topic of the hematoma. What is a hematoma? Hematoma means missing the mark in the sport of spear throwing. So you must have seen in the TVs the spear throwing. So someone will hold the spear and throw at a mark. If they miss the mark and the spear goes and hits some other object, then it is called as hematomatous shot. So similarly, the nature is forming our body during fetal development. Sometimes the nature misses the mark. That means there may be some developmental error. So due to developmental error, if any mass arises, it is called as the hematoma. It is a focal developmental malformation of a tissue with an abnormal proportion of tissue in that site resembling a tumor. So there is a malformation of the tissue with an abnormal proportion of tissue in that site resembling a tumor. So there will be abnormal mass. For example, in this area, there should be 1 million capillaries, blood capillaries. Instead of 1 million capillaries, if there are 10 million capillaries in this small area, then what will happen? There will be mass of capillary tissue here. Then it's called as hematoma. And that hematoma is because of blood vessels. So then we call this as hemangioma. Similarly, lymphatic vessels. So the other feature of hematoma is they are present since birth. They grow during childhood along with the surrounding tissues at the same rate because they are all after all normal tissue. That's why they also grow up to puberty. Later, they cease to grow and sometimes even regress. They do not invade or they do not cause metastasis. These malformations can be of blood vessels, lymphatic vessels, nerve fibers, or melanocytes. Vascular malformations, that is called the hemangiomas. So the vascular malformations, they are called the hemangiomas. Many of the vascular lesions are hematomatous. That means all vascular malformations are not hemangiomas. Some of them are hematomatous. That means some of them are congenital. From the birth itself, they are present. But some are due to acquired lesions. So first of all, we will study here only these hematomatous vascular malformations. Then we will study about the acquired vascular malformations. So to just list them out, vascular lesions, congenital malformations, they are called hemangioma. Acquired lesions, there are various acquired lesions. They resemble like hemangiomas, but they are not hemangiomas. They are Campbell D. Morgan's spots, spider nevus, glomus tumor, pyogenic granuloma, angiosarcoma, Kaposi's sarcoma. So these are all the acquired vascular lesions. So first of all, let's study about the hemangioma. Later, we will touch upon these acquired lesions. Hemangioma. A hemangioma is a hematomatous malformation of blood vessels with overgrowth of vascular tissue. The overgrowth may be capillaries, veins, or arteries. It is not a tumor. It passes through two phases. Proliferative phase, initially there is proliferation of the lesion and sometimes with papillary and keratinized surface. So initially the vascular lesion, it increases. After it is appears as some vascular malformation patch over the skin, it gradually increases for some time. That is called the proliferation phase. Involution phase, later it gradually involutes. As it is involuting, the color fades and the lesion shrinks and ultimately disappears. Sites of occurrence, skin and subcutaneous tissues commonly. So these hemangiomas or the vascular malformations usually occur over the skin and subcutaneous tissues. Sometimes they can occur in any organ. We have seen hemangioma of the liver, hemangiomas of the spleen, hemangiomas in the brain. Types, depending upon the type of affected blood vessels, hemangioma is classified as capillary, cavernous, and plexiform. Capillary hemangioma. That means there is capillaries overgrowth at one place, manifesting like a vascular malformation or vascular lesion. So capillary hemangioma may manifest as three varieties: as Salmon's patch, Port Weinstein, and strawberry angioma. Salmon's patch. So you can see here the pink patches here because they are due to the excessive development of capillaries in this region. The cause is persistent fetal dermal circulation, which disappear in 1 year. So the Salmon patch disappears in 1 year time. It presents as a flat, warm, not elevated patch of red or pink network of small capillaries. It occurs at birth and disappears usually by first year of age. It commonly occurs on the face or nape of the neck. There is sign of emptying. What is the sign of emptying? What is the sign of emptying? How do you demonstrate for hemangioma, sign of emptying? How do you demonstrate? Okay, what you do is you take a glass slide because it's a small lesion. When you press it like this, you can't observe blanching. That's why you take a glass slide and press it over. So through the glass, you will be able to appreciate the blanching of the lesion. So that is how you demonstrate the sign of emptying with the help of a glass slide. Port wine stain, it is due to defective maturation of cutaneous sympathetic innervation in the fetus, leading to localized capillary dermal capillary dilatation. You can see here, you can see on the face as well as on the chest wall, there is this. It manifests at birth as dark pink staining of the skin with local warmth, and it doesn't alter during the rest of the life. Sign of emptying is present. Now you can see here, there is port wine stain here. You take a glass slide and press it over. You can see the blanching here. So these are examples of the port wine stain. Syndromes associated with port wine stain: Stooge-Weber's syndrome. This is port wine stain on the face with intracerebral hemangioma. Osler-Rendu-Weber syndrome: multiple hemangiomata of the skin, that is face, mouth, nose, nail folds, and mucous membranes, and rarely the lungs. Protease syndrome: port wine stain plus regional gigantism plus lymphangioma. Klippel-Trenaunay syndrome: the congenital varicose veins, port wine stain, bone and soft tissue deformity due to local gigantism. So this is called the Klippel-Trenaunay syndrome. It is one of the frequently asked short notes in the examination. So after Salmon patch and port wine stain, the other lesion due to capillary hemangioma is strawberry hemangioma. It manifests as a bluish or pink, slightly elevated mass. Salmon patch and port wine stain are flush with the skin. There is no elevation. You will observe it as a macule, pigmented macule, which blanches on pressure. But strawberry angioma, slightly elevated mass, resembling that of a strawberry or raspberry, with the sign of emptying. It presents few weeks after birth and grows rapidly for some weeks with child for 1 year. So it may not appear immediately after birth. It may appear 1 or 2 weeks or 3 weeks afterwards. Then it grows rapidly for some weeks along with the child up to 1 year. And later it starts involuting by 7 or 8 years. So gradually it disappears by 8 years. It contains dilated blood vessels with thin walls. The Salmon's patch and port wine stain cannot be differentiated before 1 year. If it persists, it is port wine stain. If it disappears, it is Salmon's patch. That is how we differentiate. So within 1 year, you just simply say it is a capillary hemangioma, most probably port wine stain or Salmon's patch. So this is the sign of emptying with the help of a glass slide. Sites of occurrence: skin, subcutaneous tissues, and internal organs like liver and gut. In dark skinned individuals, it appears like brownish elevated mass, spongy mass. Complications, if it occurs on the face, it gives cosmetic problem for the child. Sometimes it may bleed, ulcerate. Usually ulceration occurs by application of some counter irritants. So the parents, what they do is they put some amurtanjan, jendu balm like that over it and rub it for 2 or 3 days. So with that, there will be ulceration. So no counter irritants should be applied to the lesion. In case of large hemangiomata, there may be associated thrombocytopenia. They may get calcified. They may be infected, leading to sepsemia. May be associated with internal hemangioma of the ipsilateral brain, then we call it as Stooge-Weber syndrome. Presence of hemangioma on the midline of the back suggests spina bifida occulta. Treatment, application of cosmetics to mask the blemish and watchful expectancy for the lesions to involute naturally. Because all these lesions, they gradually involute by 7th or 8th year of age. So you can ask the parents to just use some cosmetics to mask the appearance of hemangioma, and they can wait till the lesion involutes. If the lesion doesn't involute or if it's large in size, then you can try to thrombose the capillary vessels by applying carbon dioxide snow. Intense pulse light and pulse dye laser. So this particular laser have affinity of these laser rays to capillary blood vessels. So because when you apply this laser, these blood vessels they get thrombosed and later they become fibrous. Or you can inject intralesional injections of sclerosant liquid like boiling water, poidokinol, ethoxysclerol, etc. into the lesion. So with that, there will be sclerosis or thrombosis of the vessel wall, resulting in obliteration of the hemangioma. Systemic corticosteroids help to reduce the size of the large hemangioma. It occurs in not in all the patients, only 60% of the cases they will have the reduction. Okay, Santi has raised a doubt. Do these capillaries have connection with normal circulation? Yes. The students, please answer this doubt. Do they have communication? Yes or not? Yes, they have communication. Otherwise, they don't empty on pressure. Sign of emptying always indicate that there is communication with the circulation. Yes, okay. Now, the venous hemangioma, also called as the cavernous hemangioma. So there will be a mass of veins. So the veins can be seen as worms. So you can see here, there is a mass here. You can see slight bluish tinge of the skin here. So when you press them, they are getting emptied. Venous hemangioma is uncommon. It presents since birth. It consists of multiple venous channels of different sizes, clinically presenting as a mass of tough vessels with sign of emptying. May extend over large areas, usually one whole limb. On lower limb, it may manifest as varicose veins. Sometimes it may be associated with neurofibroma or lipoma. In such a case, it is not totally compressible. It doesn't involute. It persists like that, even after 5 years or 7 years. You can see here, there is a mass of hemangioma. Similarly here, treatment conservative, elastic stockings to the limbs. That means you apply elastic compression band-aids to the limbs, or you go for injection sclerotherapy. That means if some drugs are injected into the veins, they get thrombosed and they get later fibrosed. So this is called sclerosis. So this is called sclerotherapy. Surgical management, again you can use laser or you can use excision and reconstructive procedure. It is rarely advised because the hemangioma, it looks like a swelling of subcutaneous tissues. But once you start dissecting, you will see it going deep into the muscles. From the muscles, it will be there even up to the bones. So, for a non-neoplastic lesion, you have to do a very wide resection. The skin, the subcutaneous tissues, the muscles, the bones. So everything has to be excised. And later, you have to do a reconstructive procedure. The flap procedure reconstruction must be done. So why to go for such a major operation for a simple thing like hemangioma, which can be corrected by injection sclerotherapy or by laser? Then arterial hemangioma. So here there is excess amount of arterioles or arteries. Congenital presents as pulsating warm swelling of arteries with sign of compressibility and obliteration of and they get obliterated on occlusion of the feeding artery. So it is an arteriovenous fistula. It is actually an arteriovenous fistula, but earlier the surgeons thought that it is mass of arteries. Actually, it is not mass of arteries. It is only one single artery is there. It is communicating directly with the veins. So when the arteries communicate with the veins, what will happen to the vein wall? Tell me. What will happen to the veins wall? Very good. They get arterialized. So they feel thickened and they will be pulsating. So that is why they are very easy to be mistaken for arteries. So arteriovenous fistula actually is formed by arteries and veins, but on palpation you will feel all the vessels are thick walled and they are pulsating. So you will mistake them to be all are arteries, but in fact they are not arteries. It is a arteriovenous fistula where veins are becoming like arteries. Cirrhosis aneurysm is a type of AV fistula occurring on the scalp. Treatment same as AV fistula. Treatment of the plexiform hemangioma is just like treatment of AV fistula. What is the treatment of AV fistula? What is the best treatment for AV fistula? What is the best treatment for AV fistula? The best treatment for AV fistula is therapeutic embolization. Very good, Manogya. You are right. It is therapeutic embolization. So you can embolize the feeding arteries, then automatically the whole veins which were engorged, they collapse. So that is about the congenital hemangioma. So there are three varieties: Salmon's patch, which disappears by first year of life, then Portwine stain. So these two are macular lesions where there is no elevated mass. The third variety is the strawberry hemangioma, where there is a strawberry like pink mass over the skin with sign of emptying. So those are the congenital vascular malformations. Then there is also the venous malformations. There is venous hemangioma. Then there is arteriovenous fistula manifesting like the plexiform hemangioma. Now we will go to the acquired vascular malformations. So these are not hematomas. Because we are talking about vascular lesions, so I have included these things also here. So they are not hematomas. Examples being spider nevus. It may appear and disappear spontaneously in puberty and in pregnant women. It is also a sign of hepatic insufficiency. That means in cirrhosis also you notice these spider nevi. You can see here there is a central dilated arteriole with peripheral radiating channels of blood vessels, dilated blood vessels. So this is called the spider nevus. Just like a cobweb. Then the Campbell D. Morgan spots. It is AV fistula in dermal capillaries. So you can see these red or pink spots in the skin. So they are seen in people more than 45 years age. So quite often they are seen on the trunks of men or women over 45 years of age. They occur in old people and in cirrhotics also. Then the third acquired vascular malformation is glomus tumor or glomangioma. It is tumor from cutaneous glomus. What is glomus? It is composed of a tortuous arteriole communicating with a venule and surrounded by network of small nerves. These specialized organs regulate the temperature and are mainly situated in the limbs, especially in the nail beds. Clinical features: compressible, severely painful, small swelling under the nail bed or as subcutaneous swellings. Sometimes we may present with paroxysmal pain in the nail bed without swelling. Pain is aggravated on exposure to cold. So this is called the glomangioma or glomus tumor. Treatment is excision. The other acquired vascular malformation is the pyogenic granuloma, also known as the granuloma pyogenicum. So here you can see a mass of granular tissue. So you can see all the granular tissue projecting outside on the skin as a mass. And because this granular tissue contains a lot of new blood vessels, so on touching of this, there will be bleeding. You can see the blood here. Single, soft or firm, pedunculated or sessile hemangioma-like mass of 1 to 2 centimeters in diameter. It may ulcerate. It is slow growing and bleeds on trivial trauma. Histology, it appears like hemangioma. That's why if you send it for the pathologist gives report as hemangioma. Treatment is excision. Then multiple mucosal hemangiomas are AV malformations. They present as hemorrhage from the gut or urinary tract, because if this hemangioma is there or the mucosa of the alimentary tract, the patient will manifest with melena. If they are there in the urinary tract, the patient's urine will be having hematuria. So these are the benign acquired vascular malformations. There are malignant vascular malformations, but they are discussed in the topic on malignant lesions. Next is the lymphangioma. Localized congenital lymph vesicle or lymph vessel dilatation due to hematomatous malformation. You can see here over the skin you see a lot of blebs. These blebs are nothing but the dilated lymph channels. So there are localized collection of lymph vessel dilatation. This is a developmental malformations. Present as brownish papules or vesicles or wart-like excrescences having small vesicles. So some of them are brown colored. And if it is left like that, after some time, the skin over this particular surface becomes papular. And sometimes there will be wart-like excrescences will be developing over this. This is all because the lymph causes a lot of irritation to the keratin layer. So the keratin layer hypertrophies and forms this brown color rough surface over the lymphangiomatous vesicles. Treatment, excision if cosmetic, recurrence is common. Cavernous lymphangioma, it is also called as cystic hygroma. Etiology, it is hematomatous malformation of lymphatic vessels which fail to communicate with the main lymphatic system. During development, the lymph channels will be developing in the tissues. And then later, there will be main lymphatic ducts which are communicating with the blood vessel. So the ultimate thing what the nature has to do is to provide communication between the lymphatic channels in the tissues with the lymph ducts that are there in the body. The main lymphatic ducts are the jugular lymph trunks, the subclavian lymph trunk of the upper limb, and the thoracic duct and right lymphatic duct of the trunk. So all the lymphatic plexuses they will have communication with these lymph ducts. If any part of the lymphatics which are developing fail to get communication with the parent trunk or main trunk, that will lead to an accumulation of lymphatic vessels which are not communicating. So they're collecting lymph, but they are not emptying. So they gradually dilate and they form a lymphangiomatous mass. That is the genesis of the cavernous lymphangioma. Sites, neck, axilla, cheek, lip, and tongue. So when it affects the tongue, it is called as the macroglossia. If it affects the tongue, it is called as the macrocelia. That means the tongue and lip, they appear very swollen. Then they may occur in the breast, rarely groin. Lymphangioma of the neck and breast are also called as the hydrocele of the neck and breast respectively. Pathology, it is a mass of dilated lymphatic vessels extending into surrounding soft tissues, fascia, and muscles. These vessels have lost their communication with the main lymphatic duct and hence they are dilated and swelling is partially compressible with the part of the lymph from one part of the swelling passing into the another part. If you press it, there will be slight compressibility, not complete compressibility. Why? Because when you press it here, so this part of the lymphatic vessels which are having lymph, they because they're communicating with the other lymphatic vessels by the side, so part of it empties into those lymphatics and they appear compressed. So these are the examples of the cystic hygroma. They can be very large. Sometimes they will cause obstruction of the labor also. So this child is having a hemangioma of the neck region and this child is having hemangioma of the axillary region. Clinical features present usually during early infancy and occasionally at birth. Growth, slow growth, occasionally grows rapidly, especially if superadded infection develops from the nasopharynx. Appearance, soft, fluctuant, diffuse swelling with brilliant translucency and is partially compressible. So when you put the torch here, you can see the illumination. Treatment is excision of all the cysts. The dissection is difficult because of involvement of soft tissues of the neck with tiny cysts. Because if you don't remove those tiny cysts, there will be a lot of oozing as well as there will be recurrence. Because of the diffuse nature of the lesion, which is present not only in the skin and subcutaneous tissues but also in the muscle, fascia, and underlying structures. So it is always preferable. Sometimes it's preferable to go for a modified neck dissection. That is just like block dissection, where you remove the sternomastoid, the deep fascia of the neck, along with the lymphatics and lymph nodes. So that is about the lymphangioma. Now we'll go to the next topic, the neurofibroma. Okay, neurofibroma. It arises from the endoneurium, the connective tissue of the nerve sheath. The connective tissue of the nerve sheath is arranged in three groups. You can see this is the cut section of a nerve fiber. These are all the nerve fibers. The nerve fibers are bundled into groups. Each nerve fiber is surrounded by fibrous tissue that is called the endoneurium. And a bundle of nerve fibers, it is surrounded by, again, one facial layer that is called the perineurium. It is called the perineurium. So this is the bundle where you can see perineurium covering. And all the bundles are grouped by another facial covering that is called epineurium. So there are three sheets for the nerve fiber: endoneurium, perineurium, and epineurium. Neurofibroma is a hematoma. It presents like a single or multiple lesions. When it is multiple, we call it as multiple neurofibromatosis. It is intimately associated with nerve fibers which run through the tumor. So you can see here, this is the neurofibroma. So there is thickening and enlargement of the nerve. And the nerve fibers, they pass through this neurofibromatous mass. And here you can see this is a benign tumor of the nerve fiber sheath. This is called the schwannoma. That means the schwann cell, they cover the nerve fibers. So these schwann cells, they undergo neoplasm and they may present like a mass like this. And in this case, there will be displacement of the nerve. But here, the nerve fibers pass through the neurofibroma, but in schwannoma, the nerve fibers are displaced to one side. Types of neurofibroma: solitary neurofibroma, Multiple neurofibromatosis or generalized neurofibromatosis is also called the von Reckling-Hassen's disease. Then plexiform neurofibromatosis. So these are the three varieties. Solitary neurofibroma, it is a form spherical subcutaneous or cutaneous mass of varying size from peanut to cricket ball size. There is no neuronal deficit. Other features are like that of schwannoma. It is a smooth form swelling which moves perpendicular to the axis of the nerve and not along the axis of the nerve, with paresthesia over the distribution of the nerve if it is tapped. So, for example, this is just like a small pea that is there in the skin. That is why you are able to lift the mass along with the skin here. The nerve fibers just they pass through this. So if you press it, there will be some tingling sensation may be there. If it is a large mass arising from a large nerve, then you can demonstrate one sign, that is you will be able to move the swelling perpendicular to the axis of the fiber, but you cannot move it along the nerve fiber. Just I will demonstrate, I will show you here. Now you can see, let us suppose this is a nerve fiber passing like this. A mass arises from this nerve fiber. So you can hold the nerve fiber and you will be able to move it transversely. But along the axis, you can't move it. So perpendicular to the axis, like a pendulum, you will be able to move it. But along the axis, you cannot move it. So that is the characteristic feature of a nerve swelling. And when you tap it, there may be some paresthesia over the distribution of the nerve. Treatment enucleation is not possible because all the nerve fibers are going through that one. You can't separately remove it apart from the nerve fibers. So when you remove it, the nerve fibers also will be damaged. So excision causes nerve damage. Skin neurofibromas can be excised, but neurofibroma arising from major nerves like ulnar nerve or brachial plexus, they cannot be excised. You just leave it like that. Then generalized neurofibromatosis is called the von Reckling-Hassen's disease. You can see here there are multiple nodules. These are all neurofibromatous nodules developing over the skin. So it is a hereditary disease. It is an autosomal dominant disease. Multiple tumors arise from endoneurium of cranial, spinal, peripheral nerves of the skin and subcutaneous tissues. So these are all appear from the nerve fibers. There will be associated macular brown pigmentation of the skin called capsuloid spots. So coffee-like spots over the skin. So there will be associated coffee-like staining of the skin lesions may be there. You can see this is the capsuloid spot. The swellings are small to very large size. They may be associated with plexiform neurofibroma. Malignant transformation can take place. You can say this gentleman is having multiple neurofibromatosis, with one of the neurofibromas has become the neurofibroma sarcomata. So it is a hereditary neurofibroma where father and child both have the neurofibromata. There are multiple neurofibromas in this patient, along with neurofibroma occurring in the spinal cord. So because of that, the vertebra have got deformed and producing kyphosis here. You can see the kyphosis. So you can see the whole body will be riddled with this neurofibromatosis. So that is about multiple neurofibromatosis, also called the von Recklinghausen's disease. Then plexiform neurofibromatosis. In the multiple neurofibromatosis, you are seeing spherical masses occur over the nerve. In plexiform neurofibromatosis, there will be complete thickening of the nerve fiber. The nerve fiber may be small or large. It becomes enormously thickened and pendulous. So you can see here, this is all neurofibroma. You will feel a firm tissue here, firm soft tissue here. This is all firm soft tissue. So it is due to enormous thickening of the nerves due to myxofibromatous degeneration of the endoneurium. The involved skin is thickened and hangs down in pendulous folds. It usually affects fifth cranial nerve, causing gross deformity of the face. The underlying bone is also eroded here. It may produce gross deformity. This is also called elephant man. Sometimes it produces such great deformity, so the fellow may have something like a trunk. So it looks like the elephant man. So you can see here an extreme neurofibromatosis occurring to the face. So there are such large pendulous folds of skin and subcutaneous tissues here. Even the eyes are covered away. The nose is covered. So this is the picture of a severe neurofibromatosis. This is plexiform neurofibromatosis of the hand. You can see the pendulous folds for the limb. So this is all plexiform neurofibroma. So they may be associated with the solitary or multiple neurofibromatosis. So the plexiform neurofibromatosis is nothing but enormous thickening of the nerve fibers with associated myxomatous degeneration. So you can see here the hand. So there is a lot of thickening of the skin here. And here you can see there is pendulous folds of skin. Why? Because all the dermal nerves here, they have become enormously thickened and they got degenerated. So you find a firm mass here hanging from the skin with surrounding skin also is very much thickened. So this is the plexiform neurofibromatosis. And this plexiform neurofibromatosis may be associated with multiple neurofibromatosis. This is not due to multiplication of the nerve cells. This is due to thickening of the endoneurium of the nerve fiber. Nerve cell is axon. The nerve cell is not at all involved in this neurofibromatosis process. The tissue that is involved here is thickening of the endoneurium of the nerve fiber. Thickening is due to myxomatous and fibrous tissue. So because of this enormous thickening of the nerve endoneurium of the nerve fiber, so you will see these pendulous folds and thickening of the skin. So this thickening is not uniform. It is asymmetrical. That's why you are seeing this asymmetrical projections or masses over the skin. So you can see here plexiform neurofibromatosis. This is again another plexiform neurofibromatosis. You can see one more mass here. Then there is one more mass here. So the skin also is very much thickened here. So that is about plexiform neurofibromatosis. Is it clear? So the nerve fiber hematomatous being solitary neurofibroma, multiple neurofibromatosis, plexiform neurofibromatosis. So these are the three varieties of the neurofibroma or the hematomatous lesions of the nerve fibers. It is all because of the thickening of endoneurium of the nerve fibers. Okay, if you have no doubts, we will go to the topic of the nevus or the mole. During fetal life, the melanocytes migrate from neural crust to basal epidermis. The melanocytes they form in the neural crust, and from the neural crust they travel to the epidermis of the whole skin. When aggregate with abundant melanin in the epidermis or dermis or at their junction, they form moles or nevi. These aggregations are due to proliferation of melanocytes due to a developmental abnormality. Hence, it is an hematoma and not a tumor. Pathology, melanocytes. These are clear, round cells derived from neural crust. These cells are present in the basal layer of the epidermis. Their number is same in white-skinned individuals and black-skinned individuals. They supply melanin to the surrounding keratinocytes. And because of this melanin, the skin pigmentation occurs. So the pigmented keratinocytes protect the underlying basal layer from the ultraviolet radiation. Types of moles, these are the types of moles, congenital and acquired. In the acquired, these are all the types of moles. Of course, we will discuss one after the other. Congenital nevus. Present at birth, single or multiple, size usually more than 1.5 centimeters, sometimes may be very large, covering extensive areas of skin. You can see here, very large area of the skin is being covered by this congenital nevus. So then it is called the giant congenital nevus or giant hairy nevus. If it has hair, then it is called as giant hairy nevus. It may be flat or raised or papular. It may be hairy or hairless. It may become malignant before puberty, especially in large nevi. So some of these congenital giant nevi may become malignant also. Then epidermal nevus. So the types of nevi let us study. So acquired congenital. Congenital already we have seen. Now we will study about the acquired. The types of acquired being epidermal nevus. This is commonly seen simple nevus, occurs in infancy and childhood. It is less than 5 millimeters in size. It is a pigmented macule. So most of these are there for all of us. And they are taken as birthmarks. So whenever some government authority wants to identify you, they will take these as identification marks for you. So these are the epidermal nevi. They cover the skin, nail bed, mucocutaneous junctions like anorectum, conjunctiva, and meninges. The next is the junctional nevus. Melanocytes proliferate at the junction of basal layer and the epidermis and the dermis. So this is the basal layer and this is the dermal layer. So at their junction they proliferate. Clinical manifestation as a pigmented macule or flat nevus, which may be papular like this. It becomes little larger, 5 mm to 7 mm. Age children and adolescents. It may progress to form compound or intradermal nevus with advancing age. So these can progress into the dermis with age. It has no malignant potential as thought before. Then after epidermal and junctional nevi, there is compound nevus. Some of the melanocytes at the junction of the epidermis and dermis detach into the dermis and form islands of naval cells in the dermis. As adolescents, they manifest as maculopapular pigmented lesions. So it is not only a macular lesion, but there is associated pigmented, sorry, papules will be there on the surface. So this is the junctional part and this is the compound part. Then dermal nevus, most nevi become dermal nevi by third or fourth decade of life. Elevated, lightly pigmented papules commonly occurring on the face. Next is pigeon nevus. This reddish brown nodule occurring in children. These are all various types of nevi we are discussing. They are not there from the birth, they occur in the middle life or in childhood. So reddish brown nodules occurring in the children grows rapidly initially and has to be differentiated from melanoma. Later they become static, that means they don't grow. Spindle cell nevus, dense black lesions that contain spindle cells, they may become malignant. Then halo nevus. A halo depigmentation may appear around any nevus due to antibody response. You can see a nevus here and surrounding it there is a white or paler region. This is all because of depigmentation due to antibody response to these melanocyte antigens. Capsuloid spots, just now we have discussed in the, it may be associated with the multiple neurofibromatosis. So it is multiple coffee-colored macules of varying sizes. They are associated with multiple neurofibromatosis. Nevus pilus, it appears like capsuloid spot but with hyperpigmented specules. Then Mongolian spot, it is congenital blue-gray macule seen over the sacral area. Some children, if you see, before first year of age, you will see this pigmentation over the buttocks and sacrum. Initially, color deepens and regresses by seventh year of age. Nevi of Otto and Ito presents as blue or gray macule in the ophthalmic and maxillary dermatomes of the trigeminal nerve. So they form a big gray macule in the dermatome supplied by the facial nerve, sorry, trigeminal nerve. It is common in women, age infants and adolescents, common in Oriental and African women. Then blue nevus, it is due to collection of melanocytes in the dermis due to arrest in the transit of melanocytes from neural crust to basal layer. Commonly occur on the face, dorsum of the hand and feet. They occur in fourth decade usually. They manifest like dark pigmented dome shape and covered with skin, thin translucent shiny epidermis. Measures up to 1 centimeters. Malignant change is rare in this case. Earlier it was thought that they can become malignant later, but they do not become malignant here. This is blue nevus. So what is the significance of these nevi? All these nevi are benign. They never become malignant before puberty, except congenital nevus, which can become malignant. 20% of malignant melanomas arise in pre-existing moles. Some studies have shown excess number of benign moles may be a risk factor for melanoma. So that is about the moles. So the hematoma summary. Hematoma is a developmental malformation of a tissue with abnormal proportion of the tissue. It can occur to blood vessels, lymphatic vessels, nerve fibers, and melanocytes. The vascular malformations can be developmental or acquired. The congenital malformations are called hemangiomas, which may be capillary or venous. The commonest skin lesion during infancy is hemangioma. Most of them regress after 1 year of age and disappear by 7th or 8th years of age. They may be associated with other developmental malformations, and acquired malformations may occur later in life. Pigment nevi or moles are aggregation of melanocytes due to developmental abnormality and are benign. 20 to 30% of melanomas develop in long-standing benign moles. Melanoma means it is malignant melanoma. Giant congenital pigment nevus is pre-malignant. Asymmetry, border irregularity, color variation, and increase in diameter by more than 6 mm is suggestive of malignant melanoma. Neurofibroma is the developmental malformation of the endoneurium of the nerve fiber, and it may be single or multiple. The multiple or generalized neurofibromatosis is called von Reckling-Hussen's disease and is hereditary. So this is about the hematomas of the skin. Now we shall go for the neoplasms of the skin. Any doubts, please? Okay, neoplasm of the skin. Benign neoplasms of the skin. From epithelium, papilloma. From glands, it is adenoma. So epithelial tumors, papilloma, sweat gland tumors, cylindroma, syringocystadenoma, hydradenomas. Then sebaceous gland tumors, sebaceous adenoma, rhinophyma, hair follicle tumors, trichoepithelioma, pilomatrixoma, and tricholemoma. So these are the benign skin tumors. But out of this, the papilloma is the commonest one. All the other skin lesions, they present like solid skin masses. Clinically, we cannot differentiate one from the other. They just present like a solid mass of the skin. When you excise it and send it for biopsy, the biopsy report comes like this. But papilloma can be identified because it has some special features. So what is the presentation of papilloma of the skin? That is also called as the wart. It can be from squamous. In the skin, there are two types of skin epidermal layers. The outer layer is formed by squamous cells. The deeper layer is formed by the basal cells. For the squamous cells, it is called squamous cell papilloma or common wart. From the basal cell, it is called the basal cell papilloma or seborrheic wart. Squamous papilloma types, common wart, also described as the verruca vulgaris, then venereal wart. So common warts are seen anywhere on the body. They are seen as hemispherical or spherical masses on the skin with papillary surface, with keratinized papillary surface. Cause infection by human papilloma virus, that is called HPV. Site, they can occur over the hands and feet, usually. Age children and adults. Presentation small nodules, usually multiple. The papillomatous surface with surrounding rim of cornified skin. So there will be papillomatous surface and surrounding skin is cornified or thickened. Differential diagnosis. A papilloma on the sole of the foot has to be differentiated from a corn. You can see here this is the corn and this is the papilloma. Treatment local applications of podophyllin. The podophyllin is chemical cauterizing substance. So when you apply to the skin, it burns the skin there. So what you do is you apply some zinc oxide paste all around the wart. Then apply podophyllin to the wart. So with that, within 3 days or 4 days, the wart becomes black, mummified, and it drops away. Then cryotherapy, curetage, and diathermy. Then venereal warts, it's also called a condyloma accumulator. Already we have studied it in relation to the penile lesions. Accumulator means pointed. Etiology, infection by HPV virus. Sexually transmitted warty lesion. It occurs in the anogenital regions. Multiple large masses. It is precancerous. So the common wart is not premalignant, but this venereal wart is premalignant. That's about this squamous papilloma. Next is the basal cell papilloma, is also called as the seborrheic wart. It arises from the basal layer of the epidermal cells and contain melanocytes. This commonest benign skin lesion in the elderly. It occurs in old age, multiple on the trunk face, appears as pigmented hyperkeratotic lesion stuck to the skin, as if you think that something has been stuck here. And the patient also tries to remove this, but she can't remove it. Size varies from 1 millimeter to several centimeters. Next is sebaceous adenoma. It is very rare. Presents as red papules on the face, usually in the nasolabial folds, cheek, and chin. Age less than 10 years of age and increase in size and number under adolescence. Multiple sebaceous adenomas with epilepsy occur in tuberous sclerosis condition. Treatment removal by carbon dioxide snow, laser, or by surgery. Because they happen to be multiple, so it is difficult to remove all these lesions by surgery. So it is preferable to submit them for carbon dioxide snow. The carbon dioxide snow also is cauterizing effectively there. So all these raised papules under the carbon dioxide snow influence, they become black, necrose, and they drop off. Rhinophyma. It is also called as the potato nose. Pathology. It is a form of acne. It causes permanent thickening of connective tissues with hypertrophy of sebaceous glands of the nose. It presents as thickened skin of tip of the nose with markedly visible orifice of the sebaceous tubercles, sebaceous follicles. It may be associated with basal cell carcinoma. You can see here there is enormous thickening of the skin of the tip of the nose. So this is all due to connective tissue thickening. This is because of a type of sebaceous adenoma. So this is a pre-malignant condition. This can become basal cell carcinoma. Treatment, paring away the excess tissue by dermabrasion or laser. You take a blunt edged knife, and with the blunt edged knife, you scrape away all this extra growth. That means you shave off the skin off from the nose. Next is the sweat gland tumors, the cylindroma or turban tumor. It is pyridenoma from sweat glands, which can be multiple and coalesce to form turban tumor. Cryotherapy may control the progression of the disease. Sometimes you can see here, now this just looking like a turban or a cap worn by a patient. So it is the turban tumor of the skin of the scalp. Cryotherapy may control the progression of the disease. Then pylomacticoma, also called as the calcifying epithelioma of Mallarby or pylomacticsoma. This is also given a short notes question now and then. It is a benign skin tumor derived from the hair matrix. These neoplasms are relatively uncommon and occur on the face, scalp, and upper extremities. Occurs in childhood or early adulthood. Presents as a subcutaneous pink nodule or cyst with unremarkable overlaying epidermis that can range in size from 0.5 to 3 centimeters. So the size of the nodule can be anything anywhere between 0.5 to 3 centimeters. It is firm or sometimes cystic. It may have overlying skin with telangiectasia. Telangiectasia means, what do you understand by telangiectasia? Ectasia means dilatation. Telangiectasia means dilatation of capillary vessels. That's called telangiectasia. Yes. So dilated capillary vessels is called the telangiectasia. Good. Differential diagnosis: epidermoid cyst, dermoid cyst, sebaceous adenoma or carcinoma, juvenile xanthogranuloma, capillary hemangioma. Management: as it is a benign tumor, local excision and biopsy confirmation is done. Next is the malignant lesions of the skin. So as I already told you, the benign skin lesions, they manifest like a nodular elevation on the skin. When you move the skin, the lesion moves. When you move the lesion, the skin moves. Sometimes they may get ulcerated, sometimes they may get hyperkeratinized. So your diagnosis will be only if it is a papillary surface with thickened rim of keratin all around, a spherical mass. We call it as papilloma. Otherwise, all the other lesions, except the turban tumor, present like a solid mass. So you will say it is a solid swelling of the skin or solid mass lesion of the skin. It can be a sebaceous adenoma, it can be say sweat gland tumor, or it can be hair follicle tumor. So anything can be manifesting like that. So that is how you will present in the theory examination. Sorry, in the clinicals when you get a case of swelling of the skin. So first thing you must do is plane of the swelling. Is it in the skin or subcutaneous swelling? That you must always do. So there are two tests for that. One is pinchability test, the other is movement test. So all skin swellings, they are not pinchable. Then when you move the skin, the swelling moves. When the swelling is moved, the skin moves. Malignant lesions of the skin. They are classified as the epithelial and mesenchymal. Epithelial lesions, primary, squamous cell carcinoma, basal cell carcinoma, malignant melanoma, Bowen's disease, sweat gland carcinoma, sebaceous gland carcinoma, Merkel cell tumor. Then secondaries from breast, colon, bronchus, and lymphoma. So from these lesions, the secondaries may occur in the skin. We have seen secondaries to develop in the bones, in the lungs, in the liver, but secondaries can occur in the skin also. So the primary can be from the breast, colon, bronchus, or from lymphomas. Then mesodermal tumors of the skin from the dermal fibrous tissue, sarcoma can occur. This is called the dermatofibrosarcoma protuberans. Then Kaposi sarcoma, mycosis fungoides. These are the mesodermal malignant neoplasms. So first let us study about the epithelioma. It is also called as the squamous cell carcinoma or squamous cell epithelioma, epidermoid carcinoma. Cell of origin, keratinizing cells of the epidermis or its appendages. Squamous cells of the mucous membranes. So all these squamous cells of the mucous membranes, they can undergo the malignant transformation and they present as the epithelioma. Sites of occurrence, mucocutaneous junctions, there is lip, nostril, the eyelids, penis, and vulva. Then head and neck areas, exposed areas to sunshine. Back of the hand and forearm. The precancerous skin lesions, Bowman's disease, that's called the carcinoma in situ. Senile keratosis or solar keratosis, which occurs due to continued exposure to the sun. Radiation dermatitis, geroderma pigmentosum, Paget's disease of the skin, leukoplakia of the lips, cutaneous horn, keratoacanthoma. So these are all the precancerous lesions. Then chronic ulcers may become malignant. Chronic ulcers due to lupus vulgaris, long-standing venous ulcers, carcinoma develops in the eczematous edge. Then chronic granulomatous ulcers, syphilis, osteomyelitis sinus, hidradenitis suppurativa. So these are all the ulcers which can predispose to epithelioma. And epithelioma can arise from the epithelium covering the scars, especially those following burns. This is called Marjolin ulcer. Epithelioma is a epidermal tumor. Then how epidermal tumor can occur from scar? Scar is made of fibrous tissue. So how epidermal tumor can occur there? That means the thin epidermis covering the scar tissue, that is responsible for development of epithelioma. And that epithelioma developing over the scar is known as the Marjolin ulcer. Then fourth cause is due to skin irritants. Skin irritants can be due to dyes like tar, soot, mineral oil, or shale oil. The soot causes cancer, squamous cell carcinoma. Where? Can you tell me? Soot causing skin cancer. It is an epithelioma. Which part of the body? Manognya, you are telling lung. Can squamous cell carcinoma occur in the lungs? No, it cannot occur. So it is about the scrotum. It is about the scrotum. Good. Okay, Nizami, tell me what is the name of the scrotum? So when the soot causes cancer of the scrotal skin, what do you call that scrotum? What do you call that lesion? There is a lesion for that which goes with some industrial related name. Very good. ABC, very good. It is called chimney sweeper's cancer or chimney sweeper's scrotum. Very good. So the tar, soot, or mineral oil like shale oil, they can cause the chronic irritation and cancer. Then arsenic, then excessive heat. Example, Kangri cancer and Kang cancer of China. Then immunosuppressive diseases. They also predispose to cancer. This is Kangri cancer. What is Kangri cancer? What is Kangri? What is Kangri? It's very good. It is seen in Kashmir. Not in Rajasthan. It's quite opposite. You have to go to Kashmir to find the Kangri cancer. Yes, Kangri means it is a earthen pot. That means kunda. It is an earthen pot where the burning charcoal is placed inside it. And in very cold winter, to keep them off from the cold winter, then some of the people what they do is they put this fire charcoal in the earthen pot and they go and hug it. So the whole trunk front part will be in close contact with that hot earthen pot. So because of that heat, continuous heat, then they develop cancer over the abdominal wall, and that is called as the Kangri cancer. Kang cancer means again it is similar cancer occurring over the back of the trunk. In China, people in sub-Himalayan regions, because of the extreme coldness, they prefer to sleep over a hot steel bed. So they keep charcoal under the cot and they themselves lie down over that cot. So because of that, they will develop cancer over the back of the trunk. Clinical features. Incidence squamous cell carcinoma is less common than rodent ulcer. The second common is skin cancer. Age and sex occurs past middle age, common in males. It's common in men living near equator. Manifestation clinically, it may presents like an ulcer on the skin. The ulcer may occur spontaneously or as an ulcer on a pre-existing lesion like solar keratosis, Bowen's disease, erythroplasia of Corot, or on scar of a chronic ulcer. So in any of these previous lesions, an ulcer develops. Or over normal skin also it can develop as an ulcer. So begins as a small ulcer, a nodule, plaque, or warty excrescence, and that gradually grows in size and eventually manifests as one of the two types. So what are the one of the two types? It may manifest like exuberant cauliflower-like growth. So cauliflower growth is well differentiated and it spreads slowly. Verrucous carcinoma is a variant of this form which has an exophytic growth with limited invasion. Or it may manifest like irregular excavated ulcer with raised and everted margins. So it can manifest like this hyperkeratotic mass-like lesion, like cauliflower lesion, or it may manifest like an ulcerated lesion with everted margins. So the squamous cell carcinoma can manifest like two varieties, exuberant variety or excavated ulcer-like. Out of these two types, which gives good prognosis, which gives better prognosis? Tell me. Why? Why is a cauliflower and varicose type they give good prognosis? You are right. Tell me why, the reason. Yes, you must give the answer like this: well differentiated lesion. All well differentiated lesions they manifest with proliferation. Or ill differentiated tumors they manifest with ulceration. So whenever a malignant tumor is presenting like ulcer, it is highly malignant. Whenever it is presenting like a mass, it is having low malignant potential. So this is the Vercus type, where you will see hyperkeratotic masses. So there is a lot of keratin production. Keratin production is the functionality of a normal skin layer. So the tumor also is producing like this. Why? Because it has differentiation. It has well differentiation. That's why it is producing keratin-like surfaces. So this is a hypertrophic variety. This is an ulcerated variety, and these two are the ulcerated varieties. The base of the ulcer is indurated. That means it feels hard in consistency. How do you look for the base? You have to keep your fingers on either side, thumb this side, and index finger and middle finger on the this side, and you try to hold the base and lift it. So if you feel underneath this ulcer with your fingers, you will feel the induration or hardness. So that is the base. Base means on which the ulcer rests. That is the base. What you are looking at is the floor. So don't get confused between floor and base. Base is on which it lies. You can't see the base. You can feel the base with your fingers kept on either side of the ulcer. Floor, you can see the floor. Whatever that is being apparent here, that is the floor. Like malignant lesion, it has three eyes. That is, it has induration, it shows features of infiltration, it shows features of involvement. So it may infiltrate the underlying structures like fascia, muscles, nerves, or bone. That's why in every case, you must always check for the mobility of the lesion over the underlying bone. For lesions on the face or nose, oral cavity, and nose should be examined to check for infiltration. For example, this patient has come to me with a chronic ulcer over the lip. So I examined the base. It is very hard. So in every case, whenever the patient comes to with a ulcer on the cheek or swelling on the cheek, you must always look in the mouth and see on the buccal side how the buccal side is appearing. Now you can see when I put a tongue depressor and then retracted the lip to one side, you can see a big ulcerated lesion in the gingivolabial sulcus and on inner side of the lip with everted margins. So it is the simple external presentation. But when you open the oral cavity, you will see this lesion. So that's why what you have to remember is whenever a ulcer is manifesting over the face, oral cavity region, or the nose, you must look into the cavity also. Bloodstained discharge with characteristic foul smell is present from the ulcer. There may be lymph nodal metastasis. The tumor spreads by lymphatics, causing metastasis in the regional lymph nodes. The effect nodes are hard and enlarged and later fixed to the surrounding structures. Blood-borne metastasis is rare. Investigations. Biopsy. It should be taken from the growing edge of the ulcer and not from the slough in the base. So this is the ulcer. So you have to take from the edge of the ulcer. Histopathological examination shows solid columns of epithelial cell growth down into the dermis. The cells are well differentiated and show keratin formation, cell nests formation, or epithelial piles and chronic inflammatory cell infiltrates. Rarely, the cells may be anaplastic. Depending upon the differentiation, the tumor is classified by Brodess grading as well differentiated, ill differentiated, and moderate differentiated. You have to take the X-ray of the area to know about the bony infiltration. Then X-ray of the chest to evaluate for secondaries. Ultrasound scan of the abdomen in lower extremity lesions to evaluate nodes around the great vessels and for liver metastasis. So this gentleman presented with this ulcer over the scalp region. So I have taken an X-ray. You can see erosion. Differential diagnosis of squamous cell carcinoma or epithelioma. You have differentiate from basal cell carcinoma, keratoacanthoma, ulcerating sarcoma, granuloma pyogenicum. This is basal cell carcinoma. This is called keratoacanthoma, and this is a large fibrosarcomatous mass on the back with ulceration. Then granuloma pyogenicum. So this is granuloma pyogenicum, which is commonly mistaken for a squamous cell carcinoma. So what are the differentiating points between basal cell carcinoma and squamous cell carcinoma? In basal cell carcinoma, the ulcer margins are raised and purling. No lymph nodal metastasis because basal cell carcinoma doesn't spread by lymphatic vessels. It is only locally spreading lesion. Usually occurs on the face. Then keratoacanthoma, also called molluscum sebaceum, single form hemispherical nodule growing rapidly, occurs on the face and back of the hands. Margins are raised and smooth and surround a crater filled with keratinous debris. After 6 weeks, the center falls out, leaving an ulcer with rolled out edges. You can see keratin debris here, surrounded by thickened keratinized mass. After some time, few weeks, the central keratinized debris drops off, leaving behind a big crater in the mass. So this is called molluscum sebaceum. You can see the central keratinous plug has been dropped away, leaving a central ulceration. Sometimes it is difficult to differentiate from squamous cell carcinoma. Two minutes. So this is keratoacanthoma. Ulcerating sarcoma. A rapidly spreading sarcoma on subcutaneous tissues may cause pressure necrosis of the skin and cause fungating ulcer. Presence of primary tumor underneath the ulcer with undermined edges helps to make the diagnosis. So here the ulceration occurred because of stitching of the skin. So because skin has been stretched here, that has given way and formed an ulcer. So in this case, what you can do is you can just put a probe here to demonstrate the undermined skin edge. In case of squamous cell carcinoma, you can't pass a probe under the edge, but in case of sarcoma, you can pass it. Granuloma pyogenicum, it is a single, soft or firm pedunculated sessile hemangioma-like mass of 1 to 2 centimeters in diameter, slow growing and bleeds on trauma. So already we have learnt about this one in the acquired vascular lesions. Just it takes one another 5 minutes to complete the treatment. So shall I complete this? Shall I complete this treatment? Okay. Just give me 2 minutes time. I have an important call to attend. So I will make a call and then I will come back. Be online. Okay. Okay, dear students. Now let's talk about the treatment of epithelioma. So the epithelioma may be associated with secondaries in the lymph nodes. So the management must be towards the primary and for the secondaries. So treatment of primary, surgery and radiotherapy, they are the two options. Surgery, indications, well-differentiated tumor, young and fit person, operable tumors. Procedure, wide excision with clearance of 1 to 2 centimeters beyond the ulcer. Then repair of the defect by skin grafting or by flaps. So it is wide excision. So you do it wide and as well as depth wise. So wide excision means you have to remove three-dimensional, breadth-wise, length-wise, and depth-wise also. Radiotherapy indications tumors of the face and neck, old and unfit persons, poorly differentiated lesions, and recurrence after surgery. For these cases, you have to go for radiotherapy. Treatment of secondaries in the lymph nodes. Prophylactic lymph node dissection is not done. That means if the lymph nodes are not enlarged, they are not removed. If they are enlarged but suspicious due to infection, antibiotics are given for 2 weeks and FNAC is done because there may be due to secondary infection due to ulcer. So what you do is you give antibiotics for 2 weeks and then you do FNAC. If FNAC is positive or if no regression, block dissection is done. Clinically positive mobile nodes, block dissection. Fixed nodes, multiple areas of lymph nodal metastasis, poor general condition of the patient, you have to go for radiotherapy. If the nodes are fixed to the underlying structures, because the removal will cause damage to the underlying tissues also. So what you do is you just give radiotherapy. Prognosis, it depends upon the local invasion, Brodder's grade, site lesions on the extremity fare badly, etiology cancer developing on the irradiated skin, scars of burns, osteomyelitis sinuses, and chronic ulcers, and in immunosuppression patients have bad prognosis. 5-year survival rates of surgery or radiotherapy is around 95%. Marginal ulcer, it is squamous cell carcinoma from the epithelium covering a chronic ulcer, chronic scar, most often burn scar. Slow growing, painless ulcer without lymphadenopathy because it is over the scar. Scar doesn't have any lymphatic vessels, so it doesn't metastasize to the lymph nodes. Lymph node metastasis occur if the ulcer spreads to the surrounding normal skin. Treatment, wide excision including the scar and repair by skin grafting. Bowen's disease, this is squamous cell carcinoma in situ. It occurs due to solar damage, arsenic poisoning, HPV-16 virus. Clinical manifestations, slowly enlarging erythematous scaly plaque. So it just like looks like some psoriatic patch where there is erythematous scaly. Treatment, 5-fluorouracil topically, wide excision. Prognosis, the lesion may progress to squamous cell carcinoma. This is the last slide. Extramammary Paget's disease. It is intraepidermal adenocarcinoma of the apocrine glands. Whenever Paget's disease of skin means, or Paget's disease breast means, it is apocrine gland tumor. So it is an intraepidermal adenocarcinoma. Intraepidermal, that means it has not breached the basement membrane. So it is a carcinoma in situ. Sites, genital region and the glands, it is called as the erythroplasia of Carrot, perianal region, axilla. Clinical manifestations, presents as an eczematous lesion, treatment, excision. So this is about the epithelioma. Any doubts? Okay. If you have no doubts, I will close this session and let's continue the skin and soft tissue lesions tomorrow. Okay, thank you.